Hi, Dawn.
How are you?
Good.
Good morning, and thank you for joining us today for our online forum, during which we'll spotlight rural health and look at innovative solutions for equity and access in rural Ohio. I'm Amy Rowling McGee, the president of the Health Policy Institute of Ohio. Our mission is to advance evidence-informed policies that improve health, achieve equity, and lead to sustainable healthcare spending in Ohio. Our goal is that every Ohioan reaches their full health potential. The steadfast investment of our core funders and other contributors enables us to pursue this mission and goal in our work. Thank you. We also want to give a special thank you to the Ohio Center of Excellence for Behavioral Health Prevention and Promotion, who is the presenting sponsor for this year's forum series, as well as the rest of our educational event series sponsors for their generous support of our events. Throughout today's webinar, we encourage you to send in your questions via the chat or Q&A boxes. We will be monitoring both and are happy to answer any questions as time allows. The slides and resources from today's webinar are available to download on the event page of our website. Our health is closely tied to the communities in which we live, work, and play. Yet, research finds that not everyone has the same access to the resources and environments that promote health and well-being. While there are many positive aspects of living in rural areas of our state, more than 2.3 million Ohioans who live in rural counties face a number of challenges that can contribute to poor health outcomes. Next week, HPIO will release a data snapshot on health in rural Ohio. Ohio's Rural Health Improvement Plan defines Ohio's counties that are rural, partially rural, urban, and Appalachian. The snapshot we've created highlights the many factors that contribute to health in these areas. Early deaths have increased in Ohio over the past decade, with Ohioans living in rural and rural Appalachian counties dying at an early at a higher rate than Ohio overall.
If you could let me know when you need the next slide, that'd be great.
Oh, I'm sorry. Yes, next slide. So this is the slide related to premature death in rural and rural Appalachian counties. Next slide, please. And while most people in rural Ohio counties have health insurance, including employer-sponsored, Medicaid, Medicare, and other sources of insurance, next slide, access to care remains a challenge for many, in part because of a lack of providers. Here are the 10 Ohio counties with the fewest primary care providers, dental providers, and mental health providers, and they are all in rural or partially rural counties. Next slide, please. Ohioans in rural areas face many upstream challenges that contribute to poor health. For example, people in rural Appalachian counties are more likely to experience poverty than people in Ohio overall. Poverty creates barriers to health through factors like food insecurity, housing instability, and chronic stress. For example, having a very low income is also highly correlated with increased smoking rates. and rural Ohioans smoke at higher rates than Ohioans overall. Next slide, please. There are also disparities within rural communities. Research shows that some groups living in rural areas, including older adults, people with disabilities, and people of color, are more likely to experience poverty. For example, the poverty rate for Black Ohioans is twice as high as that for white Ohioans in rural counties. Today, we're going to explore these and other gaps in outcomes experienced in rural communities, as well as the work that's being done to improve healthcare access and reduce disparities and inequities in these regions of our state. I'd like to introduce Dr. Yvonne Yonk. Dr. Yonk is an associate research professor in the graduate program in public health at the University of Southern Maine Muskie School of Public Service and is the director of the Maine Rural Health Research Center. As a health economist, Dr. Yonk has over 24 years of experience working within the field of health services research. Dr. Yonk's areas of specialization include rural health, access to care, insurance, health insurance coverage, program evaluation, and cost effectiveness analysis. Good morning, Dr. Yonk.
Good morning, Amy, and thank you for that introduction. And I'd like to thank the members of the Health Policy Institute of Ohio for the invitation and the opportunity to present today and to talk about rural health inequities. Next slide. So this work was in part funded by the Federal Office of Rural Health Policy. And I'd also like to acknowledge that many of the figures that we'll be reviewing today are coming out of a chart book that was assembled by colleagues at the University of North Carolina's Shep Center for Health Services Research. Next slide. So today we'll be talking a bit about the social determinants of health and review some rural-urban health disparities, show you some examples of those health disparities, and talk about health inequities among specific rural subpopulations, and then talk about some innovative policy solutions. Next slide. So within the social determinants of health, we'll be reviewing the older adult populations, some statistics on child poverty, the labor force participation rates, uninsurance or the lack of insurance, food insecurity, and smoking rates. Next slide. So in these graphs, the statistics for rural populations are illustrated by the green dots, whereas the urban statistics are illustrated by the light blue dots. And so here we see in this figure that rural populations tend to have a higher percentage of older adults age 65 and older than urban populations. Next slide. So this figure illustrates that rural populations have higher percentages of children living in deep poverty, defined as living in households with incomes less than 50% of the poverty threshold. And this was true across all 4 census regions. Next slide. So this figure illustrates that rural populations have lower labor force participation rates in all 4 census regions. Next slide. And the uninsurance rates were much higher in rural areas across all census regions, with the South having the highest rates of uninsured. Next slide. So families living in food insecure homes were more likely to be in rural areas, with the exception of the Midwest, including Ohio. Next slide. And next, we'll be talking about rural-urban health disparities. And looking at figures that illustrate differences in rural-urban statistics regarding obesity, mortality. You see the different types of mortality, teen pregnancy, and then smoking rates. Next slide. So first, we're looking at obesity, and we see that in rural areas, the rural populations tend to have higher rates of obesity than urban populations. Next slide. The same is true for diabetes mortality. It's higher in rural areas compared to urban areas. Next slide. The same story with cancer mortality, that we see higher rates of cancer mortality in rural areas than urban areas, and that's true across all the census regions. Next slide. And now we're looking at infant mortality rates. Again, same story, different verse. Rural areas tend to have higher infant mortality rates than urban. A handful, with Mississippi having the highest rural infant mortality rate, and then a handful of states have urban mortality rates that were higher than rural, and that includes Ohio. Next slide. So suicide mortality was higher in rural areas compared to urban, and Alaska has the highest suicide rate. Next slide. You see that more deaths due to motor vehicle accidents are occurring in rural, and particularly in North Dakota, Missouri, and Arizona. Next slide. We also see higher teen pregnancy rates with the greatest disparities in the South. Next slide. Higher smoking rates in rural than in urban areas. Next slide. And here is just a quick snapshot of these rural-urban disparities in Ohio. Mortality medians tend to be higher than the national medians, with the exception of motor vehicle and suicide mortality. Smoking and obesity rates were higher in Ohio than the national median. Next slide. So next, we'll focus on specific health inequities among older populations, people with disabilities, and Black and Native American populations living in rural areas. Next slide. So I know this is a busy slide, but the references are at the bottom. And according to a 2022 study of Medicare beneficiaries, rural older adults had higher rates of hospitalization and mortality from stroke, heart attacks, and thrombolysis. Thrombolysis. There we go. While rural older adults suffered higher mortality rates also from pneumonia and COVID-19. Next slide. So compared to people without disabilities, people with disabilities tend to have lower educational levels, lower incomes, higher unemployment, and they tend to be in fair or poor health. They tend to use tobacco, and they forego physical activities and tend to be overweight or obese. And in the figure, you see that there's a higher prevalence of people living with disabilities in rural areas compared to urban areas across all census regions. Next slide. So in a 2019 study, the authors found that premature death rates were significantly higher in rural counties that have a majority of non-Hispanic Black or American Indian, Alaskan Native residents than in rural counties with a majority of non-Hispanic white residents. So they found that when they adjusted for differences in the socioeconomic characteristics of these populations, they found significant impacts of social determinants of health. So we found increased rates in rural counties with more children and higher unemployment. We also found lower premature death rates in counties with higher median incomes and more primary care providers per capita. Next slide. So compared to counties, or more specifically, compared to rural counties that were primarily non-Hispanic white, rural counties with a majority of non-Hispanic Black residents had lower median household incomes and nearly doubled the unemployment rate. And these results signal that the fundamental cause of health inequities are the ongoing impacts of structural racism. In fact, there is, and what we mean by that is there is an inequitable allocation of resources and opportunities based on race. Next slide. So taking a look at the Native American population, In rural counties with a majority of American Indian or Alaska Native residents, the unadjusted premature death rates were nearly double those of rural counties with a majority of non-Hispanic white residents. And the significant drivers contributing to this disparity include the social determinants of health, namely lower average household income, higher unemployment rates that were twice as high for the Native American communities compared to white communities, a higher percentage of the population being children, and then food insecurity rates that were 3 times higher than the rates that we were seeing in non-Hispanic white communities. Next slide. And finally, greater poverty and lack of access to care exposes rural Black and Native American communities to greater risks of developing cancer. They are experiencing poor cancer outcomes in terms of treatment and poor survival rates. And last slide. So we have seen a rather significant and persistent rural-urban health disparities and health inequities within specific rural subpopulations in the U.S. And the findings from studies that our center has been working on in terms of identifying ambulance and healthcare deserts in particular, that there is an important need to fill those gaps in ambulance and health services, and that there's an opportunity for ambulance services in particular to fill those health service gaps using innovative models such as community paramedicine, community health workers, and mobile integrated health. And there's also some movement to expand this concept of cost-based reimbursement for not only the critical access hospitals that have been enjoying cost-based reimbursement over the last decade or so, but for ambulance services in particular to also be reimbursed on a cost-based mechanism due to their low volume and often significant drive times in terms of trying to capture and break even and make up for the high costs of providing those services in rural areas. And with that last slide, thank you. And if you have any questions, please feel free to contact me. Thank you.
Thank you very much, Dr. Young. I'm wondering if there are any questions for Dr. Young. Is there anything in the chat box or Q&A box?
Not seeing any, so folks, please feel free to type those things in, and we can get to them as they come in too.
Thank you.
Great, thanks. And I noticed that there was a question in the chat regarding whether the slides will be available. Yes, they will. They'll be posted on the events page on our website. All right. Well, I think we'll move on to our next speaker, and that is Dr. Sharon Casapula. Dr. Casapula is the Director of Education and Research for the Office of Rural and Underserved Programs at the Heritage College of Osteopathic Medicine at Ohio University. The focus of her research is medical education, specifically programming related to increasing the number of physicians in rural and urban underserved communities. And Dr. Casapula is also the past president and a founding member of the Ohio Rural Health Association. Good morning. It's still morning. Dr. Casapula, how are you?
Good, thank you. And thank you for inviting me to speak today.
Thanks for joining us.
Yeah, so are we ready to go ahead and get started?
I think so.
Great. All right. As you heard earlier today, people in our rural counties are experiencing increased rates of premature mortality. Access to care is one of the factors that's contributing to poor health outcomes. You can go to the next slide. There are many factors that are influencing access to care in Ohio, and I'm going to speak about 3 of them today: rural hospital closure, maternity care deserts, and ambulance deserts. Next slide. You may have heard about hospital closures recently in the news. The fact is that many of our rural hospitals are closing because they simply aren't paid enough to cover the cost of providing care to people in rural communities. Next slide. The percentage of America's rural hospitals that are operating in the red jumped from 43% to 50% in the last 12 months. Since 2010, 167 rural hospitals have either closed or converted to a model that excludes inpatient care. And currently, 418 rural hospitals are vulnerable to closure. Next slide, please. I'm using this image with permission from the Chartist Group. This slide shows the percentage of rural hospitals that are operating in the red. The states with the darkest shading have between 80 to 100% of their rural hospitals operating in the red. This is the highest percentage the Chartist Group has ever calculated. Next slide, please. Some hospitals have decided to address financial difficulties by reducing or eliminating services, including chemotherapy and obstetrical care, or by converting to models that only offer outpatient services, such as the rural emergency hospital model. What does this mean for patients? It means longer drives to access care, longer wait times, and limited access to hospital services. Next slide, please. We have in Ohio 33 critical access hospitals. And for those of you who may not know what that designation means, a critical access hospital is a hospital located in a rural area that has no more than 25 acute care inpatient beds and maintains an average length of stay of 96 hours or less per patient. We have 73 rural health clinics, 192 federally qualified health centers. Next slide, please. 3 rural hospitals have closed in Ohio since 2010, and others are reducing services. Next slide, please. Premier Health in Troy recently shut down its labor and delivery unit. It's one of 6 rural maternity wards in Ohio that have closed in the last 2 years. The Center for Healthcare Quality and Payment Reform says there are 5 others that are under threat of closure. Last year, Kettering Health in Piqua closed its emergency services department. I want to share this brief video of their final moments.
More heinous crimes committed in Ohio by illegal immigrants.
The driver of the minivan that hit St. Luke's Hospital officially closed yesterday, and now Mercy Health has control of the assets and property of the former hospital. Financial terms of the deal have not been released. It's also still unclear what will come of the building itself. As far as St. Luke's employees, more than 400 have signed commitment letters to work at Mercy facilities. We're getting a listen tonight to the hospital's final call to Lucas County EMS. It is made by Dr. Tom Boggs, an emergency physician at St. Luke's.
After over 50 years of service to our community, the doctors, nurses, and support staff at St. Luke's Hospital request that Lucas County mark this out of service, closed to the public. We thank you all for your service, your dedication, and your friendship over the years. We wish you all the best. This is St. Luke's last call.
Wow, you really feel for all the employees there. The community came out yesterday afternoon to support the staff as well, talking about all the years spent there. For a look back at that story, and if you need any more information on St. Luke's closure, including how to get your medical records, head to WTOL.com.
Thank you. You go on to there we go. Thank you. I just wanted to pause for a moment and recognize the impact that hospital closures and a reduction in services can have at the individual level, but as well also at the community level. I'm going to move on to talk about maternity care, I want to ask you this rhetorical question. For those of you who have had children, how long did it take you to get to the hospital? How long did it take you to get to your monthly prenatal visits? Did you have to leave your county of residence to see your OB? Personally, I live in Athens, and for me, it's a rural county that is fortunate to have hospital within 8-minute drive of my house. But that's not the case for people that live in many of the rural counties in Ohio. Broadly, maternity, you can go on to the next slide. Maternity care deserts are counties that don't have a hospital or a birth center that offers obstetric care and without any obstetric providers. 267 rural hospitals stopped providing access to OB services between 2011 and 2021, which means that pregnant people now face longer travel times to access OB care, which poses increased risk, especially in the event of an emergency. Pregnant people who reside in a maternity care desert may receive little to no prenatal care due to the lack of providers in close proximity. Next slide. This map represents the percentage of rural hospitals that stopped offering OB services between 2011 and 2021. 41 to 50% of rural hospitals in those states with the darkest shading have stopped offering OB services. Ohio falls in the 21 to 30% group. I was surprised to learn that there are less than 10 rural hospitals in our neighbor, West Virginia, that are currently providing OB services. Next slide. The shaded counties on this map represent maternity care deserts in Ohio. The pink dots represent OB services, obstetricians. Currently, over half of rural hospitals in Ohio do not have OB services. If you live in a maternity care desert, you're likely to face a 30-minute drive to access a hospital with OB services. But that's a median time. For some, it will be longer. Next slide. For example, Morgan County does not have a hospital and is considered a maternity care desert. The median household income for a family of 4 in Morgan County is just over $40,000, not much over the federal poverty level. Keep that in mind. Next slide. If you are a pregnant person living, for example, in Pennsville, in the middle of Morgan County, you'll have to travel 60 minutes or more to get to the closest hospital or OB. And when we're thinking about this, we have to also consider the prenatal visits we all want pregnant people to attend. Add up the costs of gas, finding childcare, time away from work. And when you have to drive 1 hour each way, adding in the wait time for the appointment because your physician is probably overbooked and running behind as well. Plus, not everyone has the luxury of sick time. Time off may mean lost wages for some. All of this is added stress, which is not good for anyone, especially pregnant people. One Kansas study found that women who traveled 20 or more miles for prenatal care received less services and had less prenatal visits in the second trimester and overall in their pregnancy compared to women who traveled less than 19 miles for prenatal care. Next slide, please. I have another question for you. How long would you want to wait for an ambulance to arrive if you had a medical emergency? 5 minutes, 10 minutes? For some people in rural areas that are ambulance deserts, the wait time can be 25 minutes or more. Next slide. An ambulance desert was referred to earlier by Dr. Yonk, who did a lot of the research on this topic, is a census block with its geographic center outside of a 25-minute ambulance service area. More than half of the ambulance deserts that exist are in rural counties, and most rural counties, 82% of them, have at least one ambulance desert. Next slide, please. This is a map from Dr. Yonk's work. This is the state of Ohio, and you can see the ambulance deserts here in dark yellow. Currently, over 12,000 people in Ohio live in an ambulance desert. Next slide, please. more than 60% of Ohio EMS administrators have had an open position for 6 months or more last year, according to a report by the Paramedic Foundation. EMS providers in rural parts of the state are hit especially hard. They cover wider areas, and many can only afford to pay a fraction of the wages offered in bigger cities. Coshocton County, for example, lost 40% of its staff in the last 2 years, and the EMS director is struggling to find new workers to take their places. And he's not alone. He says, here we run 4 crews. Oh, next slide, please. Here we run 4 crews. There are times of the day when all 4 crews are busy. So if you're the 5th caller to 911, you have to wait. Depending on where you are, that wait can be 10 minutes, 15 minutes, or half an hour. You don't want people to be fearful that when they call 911, no one is coming. But if we don't do something at some point, that's where we're headed. That's from Todd Schroyer, the director of the Coshocton County EMS. Ambulance service, next slide, is struggling in Ross County also. According to their EMS director, ambulance service is at a crossroads, and in many townships in the county, it's failing. The Ross County report stated that communities who have chosen to fund EMS services in a way that facilitates paid staffing have a much more reliable response percentage and shorter response times than those where local communities have remained volunteer. Which suggests some of the problem and solution to addressing ambulance deserts. A reliance on volunteers, budgetary constraints, low call volume, hospital closures, staffing challenges, and a lack of healthcare infrastructure all contribute to the EMS crisis that we're experiencing now with ambulance deserts. Lastly, thinking back to the hot challenges facing rural hospitals, ground transport affects hospitals as well. Rural hospitals are struggling to obtain transportation for their patients, often calling up services from urban centers to send an ambulance down to pick up a patient and return them to the urban center for care, or resorting to life flights to transfer patients to a neighboring county. Next slide, please. Something that you may have noticed on the maps that I've shared is that some counties in Southeast Ohio, maternity care deserts overlap with ambulance deserts. These are the rural and Appalachian counties you've heard about earlier that have increased health disparities as well. Reduced access to care has an immediate impact at ambulance deserts and OB deserts, but also a long-term impact on the health of a community. People in our rural communities in Ohio need advocates and real structural solutions. Next slide. The National Rural Health Association advocates for rural health broadly. I've included here some of the pending legislation that could address some of the access issues that we've talked about today. This one in particular regards increasing the number of physicians in rural places. Next slide. For those of you that are familiar with the Heritage College of Osteopathic Medicine, one of the programs that I run is called the Rural Urban Scholars Pathways Program, which was established 10 years ago with a grant from the Osteopathic Heritage Foundations. And the goal of our program is to encourage students into rural or urban underserved care. And many medical schools have programming like this. Ours is unique in that it blends rural and urban underserved interested students together. And since we've started the program, 225 students have graduated from our program, and we're happy to report that many of them are now going into practice in primary care in Ohio, which is the goal of our program. Next slide, please. The second advocacy area that the National Rural Health Association has is investing in a strong rural safety net, including this particular bill that aims to save America's rural hospitals. And the next slide. Also, accessing rural health equity. This one addresses access to ambulance services. So find out who represents you. This is what we can all do. This is the part of the solution here is find out who represents you, talk to them about these issues, and share your stories. Your stories matter. Legislators listen. You might be surprised how much of a difference that can actually make. Last slide. Clearly, there are many challenges facing rural communities in Ohio, and if there was a simple solution, we would have fixed the problem by now. Hospital closure, reduction in services, longer wait times for emergency services. There just aren't any easy solutions, but awareness and understanding is the first step, and maybe advocacy is the second. Thank you. Last slide, please. Reference slide. And that's it. Thanks.
Thanks so much, Dr. Casapula, for that very interesting presentation. We do have some questions that have been posted, so I'll ask some of those. And we have a lot of people who've added their personal testimonies and stories to the chat, which we very much appreciate. And, you know, I also want to just mention that we know that many of you who are attending today's webinar you live and work in rural areas of the state, and you're doing a lot of things day in and day out to improve access to care in your community. So we very much appreciate your work. I would encourage you to also put in the chat any promising strategies or programs that you have implemented in your communities, and any thoughts you have regarding messages or information that you wish policymakers knew. And I would say Dr. Casapula had a list of federal legislation for which advocacy would be important. Any thoughts you have around state advocacy, so that we're also carrying appropriate data and messages forward to our state legislators and other policymakers would be helpful to know too. So I guess to that end, Dr. Casapula, we have a question in the chat regarding Ohio's Medicaid managed care organizations. The questioner specifically asked what they could do to help keep rural hospitals from closing, and if there's any current projects around this. I guess I'll add to that question, is there anything that you think either state or federal policymakers could do that would prevent or mitigate the impact of hospital closures in rural areas?
Wow, that's a big question. And I don't know if I have a good answer for that. I would have to defer to my colleagues that are coming up after me. I know Dr. Corey Cronin is going to be speaking in a minute, and this is kind of in his wheelhouse. So I'm going to toss that question over to Corey. And
all right, heads up, Dr. Cronin, it's coming your way.
I think that's going to be a question for somebody who has studied hospital finance and and is better qualified to answer that. But I appreciate the question, and I'm glad people are asking it.
Well, we have another question, which was, could you share any additional information on the strategy? I think it was a piece of federal legislation that you shared to increase the number of rural physicians.
Sure. I can speak to that a little bit. I think one of the things that we know about increasing the number of physicians practicing in rural places is physicians tend to practice where they train. So if we train physicians in rural places, they are likely to put their roots there. So we need to increase the number of training opportunities for physicians in rural places. Through for example, the rural residency grant, a planning grant, and some of the other increased access to training slots for rural students. Many hospitals are in urban places, but if we can open residency programs that are in rural communities, then we're likely to increase the number of physicians that are practicing in them.
I'm wondering if you have any thoughts related to job creation and economic development in rural areas, and the extent to which those types of strategies could impact access to care in rural areas of the state.
So if I understand your question correctly, you're asking about economic development in rural communities and how that connects to increased access to care?
Mm-hmm.
Yes, yes, I think that anytime that we are able to increase the economic situation for families, that there's a likelihood that that will result in increased access to care for multiple reasons. We're addressing the social determinants of health, but also thinking about addressing those structural and underlying determinants as well. You know, I think that that's going to increase access for everybody in a community.
Yeah, because it seems to me that one of the reasons why some providers don't serve in rural areas of the state is that there's not as much of a patient population to make it economically feasible for them. So that if there are thriving businesses in these communities, they're more workers will be attracted to those parts of the state, which would then bring in more potential revenue for providers. Does that hypothesis seem?
Yeah, absolutely. I think that's part of it. I think, you know, doctors have, you know, families with kids. They're looking at the quality of schools. They're looking at the resources that are available for their own families. And, you know, if we can increase the economic resources and the resources that are available in all rural communities, then it's going to be good for everyone.
Yep. Okay, great. And I'll just read a comment from Shay Sanchez, who's with the Sisters Health Foundation. She mentioned that at the foundation, they've partnered with the West Virginia Behavioral Health Agency and a university to pay for social work or counseling students housing and transportation fees when they're ready for their internship in the rural region. So that sounds like a great strategy and a wonderful example of philanthropy's role in developing solutions. Oh boy, lots of people are putting great things in the chat. Stephanie Gilligan, who's with the OSU Wexner Medical Center, says that they recently launched an initiative to train physicians who want to practice medicine in a community-based setting. And Bree Miller has posted some information from the Ohio Rural Health Association about advocacy strategies. Dr. Young added, it's difficult to recruit physicians to rural areas that don't have good schools for their children or jobs for their spouses.
Yes.
That's an important point. HPIO colleagues, are there any other questions that I have missed?
No, I think you hit it.
Great. Thanks, everyone.
Thank you, Dr. Casapula. All right, so I'm going to encourage everyone to stretch a little bit while we transition to our panel. Maybe take a few deep cleansing breaths. This is heavy material here that we're covering today. We appreciate your participation and your attentiveness throughout the webinar. We're going to do a few poll questions very quickly, and we would appreciate your feedback while we post those poll questions here. So, and remember to scroll down. There are a total of 6 questions here in this first round of poll questions. We would very much like to have your feedback related to the content you've had already today. We use this information to plan our future events. So we very much appreciate you taking a moment to complete these questions. And if you have any other feedback that you'd like to share, of course, you can at any time reach out to us individually at HPIO. All of our emails are posted on our website, or if you would like, you can put any kind of comments in the chat too. I see a comment here while you're doing the poll. I'm just going to read this. This is from Randy Leidy, who is with the Ohio Appalachian Children's organization. And he says that school-based health clinics are one strategy to bring healthcare and wraparound service access to small communities. There are 35 new clinics that are currently being developed in the Appalachian region, as well as a number of others in other rural areas. More training for healthcare providers and students on health education pathways and school-based service delivery would be valuable. Great, thank you so much for that insight, Randy. Oh, and somebody said, oh no, okay. Somebody said they weren't seeing the poll questions, but now they see them. So again, please scroll down. Make sure you get to all of them. All right, now I am going to turn our attention to our panel. We have an excellent panel planned for you today of experts from right here in the state of Ohio. We've heard this morning about the equity and healthcare access challenges that are too often experienced in our rural communities. And we've also heard about the many people who are working diligently to improve health and equity in rural and Appalachian regions in our state. Our panelists today are going to highlight some examples of local approaches to addressing these challenges. We're going to hear first from Dr. Corey Cronin, who's an associate professor and co-director of the Institute to Advance Health Equity at the College of Health Sciences and Professions at OU. Also, we're going to hear from Don Schwartz, who's project manager of the Community Overdose Action Team at Public Health of Dayton and Montgomery County. We're going to also have Brandy Baker joining us, who is the co-founder of the Racial Equity Coalition of Athens County. And last, Dr. Amanda Flowers, who is a Health Advisory Board member, also of the Racial Equity Coalition of Athens County. Good afternoon, everyone.
Good afternoon.
All right, so our first question for each of you is, what do you view as the primary care access challenges in rural communities? And importantly, what strategies have you seen work best to address them? So feel free to speak a little bit to ones we've already heard about today or add to those, and in particular, focus on potential strategies and solutions.
Thanks, Amy. Thanks for the question. Thanks for having me today. And I really enjoyed the information presented thus far. In fact, I can't help but emphasize or repeat some ideas from there. And so in my work at the university with the research institute that I work with, one of the things that ties us together as researchers is an interest in health, but also an interest in community. And so we really tend to focus on kind of the upstream or the social drivers of health. And I think that's a key part of this conversation today. I've been interested in hospitals for a long time and study hospitals. And so that'll be a lot of my framing for this conversation. And in the conversation today, we've already hit on topics such as rural hospital closures, one thing I want to add to that is the importance of rural hospitals, not just for the services that they offer, but for their importance to the community. And so there's this concept of anchor organizations or anchor institutions, where there's these established organizations that are not only important for the services they provide, but how they support communities around them, how they are often the largest employer in the community, or their existence allows other businesses to exist. And so I really like that this topic's already come up today in a couple of ways. Most recently, we were talking about it in the area of physician recruitment and having strong rural communities to be a place with assets that attract people in all different professions and areas. And I think healthcare is one of those key areas where we can have a strong employer with different types and levels of jobs for the community members. And so Dr. Casapula talked about rural hospital closures. That's one thing that I study and have been looking at. And some of the good news is that while Ohio hasn't had no rural hospital closures, working with, as Dr. Young pointed out, the Shep Center data and American Hospital Association data, Ohio is actually faring pretty well compared to some of our other states that have a large rural region. We've had relatively few rural hospital closures, and so that is good. But the downside that's been mentioned today is while some of our rural hospitals are not closing, they're making difficult business decisions to stop offering some necessary services, whether that's child maternal health, emergency department, as we saw. And so if a hospital doesn't close, but those services leave the community, that leaves a large gap that's important. In some of the work I've done, I study nonprofit hospitals, and in some of the solutions or ways we could look for improvements, I'll focus on some regulations to nonprofit hospitals, as most of our hospitals in the United States are nonprofit, and that's especially true for rural hospitals. And as tax-exempt organizations, there are some expectations by federal and state government that rural hospitals do things to benefit the community. And I think that's a key area that we can look. In a recent project that a group of us have been looking at, we're looking at nationally what rural hospitals do in this area of community benefit that they report to the IRS. And there's a really interesting finding, because it's a positive finding. Hospitals in rural counties, on average, do more community benefit that can be classified as subsidized health services. And so subsidized health services are things that the hospital does not because of revenue it generates. In fact, most of the time it means they're doing these things at a loss, but they continue to do them for community need. And so it's great that our rural hospitals are making the decision to do those things. And as the conversation today has kind of tracked, holding on to these services, even if it's not a financial advantage to them. The negative we can see that, though, is that they need to do these as a loss, that they are providing services that are, as Sharon pointed out, are putting hospitals operating in the red. And so I think those are some of the key areas. The last thing the conversation today kind of brought to my mind, and then I'll stop because I want to hear from the other panelists in a response. When I think of challenges and I think of hospitals, transitions are really important everywhere, but I think they're especially important in rural areas. A lot of times rural residents, even if they start in a rural hospital, will be transferred to a hospital in an urban area for treatment. And there's a term I'm hearing more and more in health services research that concerns me, and that's the term discharge to the couch. So I think that hospitals, rural, urban, or systems of hospitals really need to think about those handoff points. When somebody is done receiving services at your facility, do they have supports within the community for their follow-up needs? Do they have referrals or people checking in? And this can relate to physical health needs, mental behavioral health needs, but those transition points and where somebody goes after they leave our places of services is something I've been thinking about a lot recently. So you again, happy to continue the conversation on the panel.
Thank you very much, Dr. Cronin. Who would like to go next?
I would, if possible, because Dr. Cronin kind of gave me a softball to lead into, what Montgomery County and public health does really well. So thank you for that, Dr. Cronin. Thank you all for having me as a part of this panel. I love the information that I'm learning. I don't necessarily like the information because we're losing, this care and this coverage for people that are vulnerable. But having discussions like this are really the first step to turning things in the right direction. So again, my name is Dawn Schwartz, and I run the Community Overdose Action Team through Public Health Dayton, Montgomery County. You know, our focus is obviously behavioral and substance use, and that type of care. But what we are seeing and what we have been seeing for several decades is a high prevalence of drug use and overdose in our rural counties. You know, we border on Preble County, which is one of the ones that was identified as having the least amount of resources. So we, you know, do cross borders and help provide resources there. But one of the things that we are able to do, and I'm able to fund through federal grants, is an outreach team that we have. Again, the outreach team is technically focused on substance use and behavioral health, but at the same time, they are able to provide linkages and handoffs, just like Dr. Cronin was speaking about at the end of his talk, to make sure that they have those community supports and linkages that they will need to follow up on whether it's their substance use and that treatment, or all the health issues that tend to spring out of substance use. So we have these peers available. We have a team of 10 right now. We're growing it. We've actually grown it by 2. We're growing it by another 2 or 4 in the next year, to where if somebody is in need of linkage, we have a 1-call number that they can reach out to. And our peers will actually go to them and start the conversation, get them where they need to be, and link them with the services that they need to for substance use, which then also results in a warm handoff and a needs assessment with some of our LSWs to determine other connections that they may need for health or social services. We also do outreach in these different communities. In Montgomery County, you know, we're a good mix of different communities. We have an urban area, we have a lot of suburban areas, and then we have a lot of rural areas also, more to the west of our county. Some of those suburban areas have large rural areas that are connected to them also, like Trotwood. And we are seeing those deserts in not only our rural areas, but also some of our urban areas that have the rural counterparts to them, where we're seeing health deserts, where we had a hospital closed several years ago that provided health care to most of our west side and our western county suburbs and villages and locations that we have. So we're needing to work with our hospital partners, our behavioral health partners, and then our community partners to make sure that we're able to serve anybody that needs our services and help make sure that the linkages that they need are put in place. Our peers will follow along until the person is in a place where they have those linkages, and then they'll continue to do follow-ups afterwards to make sure that no more linkages or connections are needed to be made. So that's kind of what we're doing here in Montgomery County and with the Community Overdose Action Team and our peer outreach team. You're muted, Amy.
Thank you. Who pays for the peer support?
So I have 2 federal grants through BJA, COSUP and COSAP that pay for the majority of our grants, and then some are levy funded. We do have behavioral health, or a treatment arm of public health called Recovery Services, and the peers that are focused on outpatient treatment are funded with levy funding. Everything else is through funding that I have been able to put in place and that my predecessor. Now, the good thing is we also have data partners, which I would suggest to anybody, if you don't have them, to try to find the financing and the connections for data partners. Our data partners, Ascend Innovations and Cordata, have been pulling they not only link us with hospital outreach and help us provide hospital outreach, but they've also been analyzing the data that they collected from the past 4 to 5 years, and they're really showing amazing outcomes for those that have been connected with our peers, and their lesser use of hospital and other medical services, as well as criminal justice and jail services.
Great, yes, and you're very fortunate to have those data partners available to you, because I know that's not accessible to everyone in the state. All right,
Yeah.
who's up next?
Can I just add one more thing?
Oh, sure.
Yeah, so, you know, again, these federal grants are right with money if you are able to find these data partners and get linked with them, and that could be your resource to pay for them. You know, Ascend and Cordata link directly into our hospital systems to identify persons that have overdosed or have substance use, and then that's how we link with them. So if anybody has any questions about funding, you know, I'll help you as much as I can. Thanks so much.
Great. All right, Brandy.
All right. So I think, Don, without knowing that you passed me the softball next, you spoke on data. And one of the things pertaining to the question about some of the primary challenges in rural communities is that specifically, I'm going to speak from a racial health equity lens, is that when people discuss the demographics of rural or Appalachian communities, they don't think of BIPOC or communities of color, or if the narrative is brought to the table as something that is in certain spaces I've said in as not being statistically significant because of the population size or the assumed population size. And so that in itself, the narrative that there are not people of color in Appalachia, or there are not enough people of color in Appalachia to focus in on some of the health access barriers, is a barrier in itself. And so being able to shift that narrative, I think, is an important strategy. And so the Racial Equity Coalition of Athens County, we formed back in 2018 with the goal of being able to elevate the voices of communities of color in Appalachia, looking at what are the challenges, what are the needs, what are the barriers. People of color came together. We looked at what those major barriers are, and health and wellness was one of those areas in terms of just being able to access care. How we define communities of color, Black, Indigenous, Hispanic, international communities whose voices are often also not represented. But the biggest question that we started with is, well, what does the data say? And of course, when you look at the data, primary data doesn't exist. It didn't exist. And so that was really the, I guess you could say, the business case for us being able to move forward to look at how we, as a community group, as an organization, can partner locally with our health improvement partners. So the Athens County Health Department, the 317 Board, the Sisters Health Foundation, and several other health partners to come together and look at how we could strategize to create a health assessment and look at how we could elevate and raise the voices of people of color. We were able to successfully secure an OHIS grant in partnership with our health improvement partners and launch a community health assessment a couple of years ago. Have formed a health advisory board, and you'll hear from Dr. Flowers in just a few seconds about just the impact of being able to engage the community first and helping them to lead and be a critical voice in the strategy and in the process of what questions to ask the community and how we could really elevate the concerns, and not just the concerns, of course, but propose solutions as to how we could address some of the systemic and structural barriers for communities of color in Appalachia. So that is the present strategy that the Racial Equity Coalition is working toward with our health improvement partners. And it's been a great uphill journey over the past few years. but we've finished our first community health assessment, and we'll be working to put out a report this fall about what the results and findings of those are, as well as the recommendations from the community. And so that was done with the help of our health advisory board. And Dr. Flowers, I'll pass the virtual mic to you to be able to share more about that.
Okay, and just to further amplify what Brandy's been highlighting and why the work of the Racial Equity Coalition is important, from my perspective as a Black mental health professional and native of rural Appalachia, in a dialogue such as this, it's essential to examine a core basic fact when it comes to challenges in accessing appropriate care. Yet, this is a conversation that's often avoided or minimized in health, educational, and professional settings, but we cannot be blind to the fact that whether conscious or unconscious, racism and discrimination manifest in medical and mental health practices concerning all avenues of the process, assessments, diagnosis, treatment approaches, medication prescriptions, and referrals. And these concerns often fashion the structural determinants of health and become even more pronounced in rural institutions where the diversity of the mental health and health workforce and educators is most limited, a factor that sometimes discourages Black, Indigenous, and people of color from seeking treatment, as it's widely understood that patients feel they receive more appropriate and adequate care from providers that look like them and share their cultural background. So why is this, you might ask? Let's just take a moment to talk about Black Americans, for example, and why we need to uplift their voices in rural communities as well, such as Black Appalachians. And much of this is what was mentioned from our surveys and our interview participants. Given our constant exposure to racism and social trauma, Black Americans and Black Appalachians have higher rates of severe depression, yet lower rates of treatment compared to white populations. However, when treated, we're less likely to receive office-based counseling for psychological stressors and more likely to be seen in emergency rooms or in primary care settings as opposed to specialty care. And while cross-cultural problems may surface in any setting, primary care providers, particularly under the constraints of managed care, may not have the time or capacity to recognize and diagnose mental disorders or to treat them adequately, especially if patients have coexisting physical disorders. And some estimates suggest about a third to half of patients with mental disorders go undiagnosed in primary care settings. And even when Black children show signs of irritability, they're less likely to receive care for depression, but their expressed emotions are more likely to be ruled as disruptive and requiring discipline, while their white peers are likely to be diagnosed with mood disorders. And then there's the fact that when Black Americans receive treatment, we're more likely to be prescribed antipsychotic medications that can have lasting negative side effects. And these medications are typically being diagnosed from a Eurocentric perspective, while research is showing that Black patients are, on average, more likely than whites to be slow metabolizers of several medications for psychosis and depression. So bias and racism undoubtedly contribute to the fact that Black Americans are less likely to achieve symptom remission and are more likely to be chronically impaired than white patients. And we will remain stagnant in addressing challenges for accessing care in rural communities and all communities, actually, until we face the underlying problem of racism and healthcare within these communities too. So the work of the Racial Equity Coalition of getting out there and taking grassroots approach to survey people in the community and interview people in the community about their experiences. And we're coming out with a report to highlight some of the findings and take the recommendations into the next step and into action.
Great, thank you. Thank you for all of those insights, Dr. Flowers. Well, we're going to move on to our second question, and this is focused on policy, surprise. What policy changes at the state and local level can further support the work that you're doing or that others are doing in your communities to improve equity and healthcare access in rural areas. And I'll just tag on to that question, the question I asked earlier around economic development, job creation, thinking about those as factors related to equity. Any policy changes that you can think of or activities that you wish policymakers were engaged in that can improve all of those factors would be helpful.
I just nationally, when we talk about like diversity, equity, inclusion, racial equity as a whole, there's been this attack or this sort of polarizing conversation around, the politics of race. But the reality is there are health and there are health consequences for not discussing it. In medical education, there is an attack on even bringing in cultural competency or making it a requirement in their curriculum. So when we talk about policy, it's really important to start where the education, where a medical educator would begin or a medical professional would begin, which is in their education pathway. But if those things are constantly being questioned as, is it viable? Is it important? We're in America, we're a melting pot. And of course, it's important if you're working with diverse communities who speak diverse languages, who come from different cultural backgrounds, who have different health indicators. And all of those things are factors based on culture, based on race. And so why be afraid to talk about it? Why be afraid to implement it? And so I think from a policy standpoint, we really have to take it seriously to incorporate these things into medical education, or we'll continue to face some of the disparities, and they'll continue to increase as we move forward in this society.
Okay. Thank you. Others?
And I would say, just to piggyback on what Brandy was mentioning, in addition to tackling some of these fragmented service delivery models and lack of research capacity for implementation of policy changes, keeping in mind that, the majority of those who need mental health care lack access to high quality mental health services. They have difficulty finding in-network mental health providers that accept new patients. There's limitations even in rural settings with having to find specialists that can be over an hour away and long waits that can last several months. But this especially impacts, rural communities when their drive to the local provider is 45 minutes or more, let alone 2 to 3 hours if they have to go to bigger cities. And then also taking in consideration the price of healthcare has, out of control for many people, and they can't afford to go to the doctor anymore. So there are a lot of times it's just cost prohibited not to go to the doctor and try to take care of health concerns at home because they can't afford it. So, any policy changes that, around the delivery models, research, trying to get the high quality services, working around policies with, in-network providers and, getting more providers and routes to specialized care, and how all of that can happen with, referrals and authorized requirements for the prior authorization for referrals and things. All of that stuff would help move the field even further.
And what are your thoughts, Dr. Flowers, around telehealth and telemental health related strategies and broadband access?
Well, I think that there are a lot of people who are loving telehealth. There are some gaps. There are some things, especially when it comes to like the mental health assessments, that you just need that face-to-face and hands-on interaction to complete them. But as far as therapy goes, a lot of people are loving it. But we reach a challenge when it comes to rural communities and internet access and broadband access, and the internet is not reliable. And because it's not reliable, we run into that challenge. But there are a lot of people who are not well versed in it because they don't use it a lot. Because I know when I go home and try to work from my mom's house, Some days I can work and some days I can't, just because it depends on whether the internet will work the entire day. So I would love to see, I know they're working on broadband in rural areas from some of the big grant programs, but I would love to see that come into play, because I think that could help people who cannot drive as far, do not have transportation, to get as far. But right now with internet, it makes it hard in rural communities.
Okay, thank you. Thank you. Don, Dr. Cronin?
Yeah, I'll jump in. And again, with a focus on healthcare organizations such as hospitals, when I think of policy recommendations, I think about this panel and the organizations that people represent. I think it speaks well that when I look to policy recommendations, I really think we could work with an existing framework. Like I said, I study nonprofit hospitals. There are regulations about their tax-exempt status in the way of community benefit, doing community health needs assessments, what Dr. Flowers talking about, doing one recently. That's an area I'm very interested in, looking forward to seeing that data. Just as a side note, it had me thinking about how we talk about population health often, but a lot of people could be using that phrase population health, but they mean very different things. Like population is defined very differently to them. And so when we do things like health needs assessments, that we all talk about, working and looking at all the different data. And then things like hospitals doing things like screening for social determinants of health and referrals for social determinants of health. So in all of this, I think there is a framework with good intentions of doing things for community health improvement, community socioeconomic development with the resources that hospitals have, and they're not paying taxes. But where I think we could strengthen that is in where those resources are directed, and especially through partnerships. That I think a lot of times there are missed opportunities for hospitals to invest in or work in collaboration with their resources with already existing organizations who are in the community and know populations or are doing good work. And I don't think we always need to reinvent brand new programs that are maybe duplicating something that has been longstanding in the community. And so if I think of a trend of rural hospitals, for example, screening patients for housing, utility bills, transportation, what do you do when you do get a flag that a patient sitting in your emergency room is food insecure? Is there a handoff you can make? Are you going to overwhelm a local community organization with those handoffs if they don't also become a valued partner with shared resources and things? And so I think we could tweak some of these things we're already starting to do and asking by having more specific goals and targets that we work towards. And like I said, encouraging partnerships, which Ohio has started to do in the community health needs assessment and implementation plan process, for example.
Hey, great. And Don?
I'm back finally. I'm sorry, my mic stopped working, but yeah, I agree with Dr. Cronin. One of the things that we do really well here in Montgomery County is form partnerships for those gaps in services. So, really understanding and identifying what the gap in service is, and then identifying who can assist you with it, and having those types of navigators. Again, ours are SUD navigators, but there's nothing stopping an organization or a hospital forming rural health navigators, that their specific focus is on working with those communities that have either the health and primary care deserts, ambulance deserts, or are purely rural and just have all the negatives that come with that in regards to their health and well-being. And not reinventing the wheel, working on what we already have, adding some pieces to it, and then start that pilot. Piloting a project is not only going to help you, work out kinks and figure out what you're doing well and what you need to do better, but it's also an opportunity to gather data to show outcomes, to continue getting funding for, the sustainability and the better of your community.
All right. So as we close out the panel. And please, if you have any questions for our panelists, put those into the chat box right now so that we can address them. But I'm going to just ask you all, as briefly as you can, to share something that you're excited about, that either you are working on or that you know others are working on, that that shows promise for improvement. So I'm gonna start. Well, okay, I hate to put you on the spot, Brandy, but you kind of looked like you might have something in mind. So I'm gonna start with you.
So I just want to say that I'm really excited about the racial health equity assessment. This has been like years in the making. I'm really excited for the community who came together just on a simple idea and ask. I'm excited for the health partners who supported a vision that when we didn't have anything. And so I'm thankful and excited about all of those things, but mostly beyond the health assessment, I'm looking forward to putting the community's recommendation into action. So that is what I'm looking forward to. I think we talk a lot about research and assessments, and this is what the data says, but then what you do with it, I think really matters, and that's what impacts the community. So I'm looking forward to the art of strategic doing. And so that is what I'm excited about and what I'm looking forward to moving forward.
Great. Dr. Flowers.
I'm excited because being a Black Appalachian and knowing that, when it comes to a lot of this work, people of color are left behind in general, but people in rural communities are like a forgotten population in general. But then you look at people of color and they are truly, and their voices are not looked at very often. And so I'm excited, and the people in the community were so excited and appreciative that we actually came in and asked their opinions without an agenda. Typically, if someone comes into these communities, they have an agenda. Sometimes it's a great agenda of, I'm going to help you do this, but no one ever asks, as a person of color living in rural Appalachia, what is your opinion? And that's the most exciting part about this is the first time this has happened. And I'm so excited to be a part of this coalition, and the excitement from the communities as far as, okay. And they were even asking questions as far as, hey, we're not going to get forgotten when you move forward with this. You're just going to focus on the people in Athens, are you? And being able to give them the promise of, no, we're coming back to you to incorporate, the recommendations and things.
Well, and I know it'll mean a lot to the folks that participated to see that final report too.
Yes.
And to know what you're doing with it too afterwards.
Absolutely. Yes.
So that is very exciting.
Yes.
Okay, Dr. Cronin.
Yeah, it may just be the crowds I hang out in, like today, but I'll say the thing I'm excited about, and try to be quick, is increased positive messaging or a rural assets first approach to things. And that's not to hide from challenges or pretend they don't exist. It is to accept challenges, but also accept that there are real things that are happening in rural communities that improve the health and socioeconomic lives of people every day. And so as we see things like brain drain as a national topic of people with education leaving rural communities, I think a counter to that are a rural asset first type of discussions and approach. And I think that's happening in health. Sharon brought up Ohio Rural Health Association, who I'm also a part of. And I think there's a really good conversation happening around this that includes not just challenges, but also assets of rural Ohio, rural America.
I'm so glad that you brought that up, because I've been looking at the list of attendees today, and it's so encouraging. Well, one, there's a lot of familiar names on the list, but to know that there are people working every day in community health centers, community behavioral health centers, hospitals, within managed care companies, within academia, the work of the Ohio Appalachian Children's Coalition, like all of these groups that are pulling together day in and day out to make sure that every Ohioan can reach their full health potential is tremendously encouraging. So I'm glad that you brought that up, Dr. Cronin. All right, last, Dawn.
Yeah, so I'm excited about the continued partnerships and collaborations that are happening in our area to widen our impact and imprint on everybody in our community. We're going to continue to broaden our outreach team who can not only, guide people into recovery and into treatment, but also, like I presented earlier, link them with many other resources for social determinants of health, including insurance applications and food inequity, things like that. I'm also really excited in our area. We do have two major health systems in our area, Kettering Health and Premier Health, and we are in talks to really get active with a street outreach and street medicine that's not only going to be able to focus on our urban and our suburban areas, but also to make it a point to have those outreach medical units and mobile units going out to our rural communities to, again, ensure that all of our community members have the opportunity for that type of linkage.
Yeah, we hadn't mentioned that at all. So I'm glad you brought that up. And I'm glad you keep mentioning food access too, because among the list of people I just rattled off, the food banks, food pantries, housing groups, economic development groups, all are important parts of the infrastructure that can make Ohio a place that's thriving and is economically and vital, or has economic vitality and a healthy population.
Right.
All right, so thank you all. Very much appreciate your participation on the panel. As we close out today's session, just have a few reminders. One of our earlier speakers talked about how important it is to communicate with our elected officials. I'm going to add to that one of the very most important things you can do is vote. And you'll have an opportunity to do that in November. In addition, though, there's many other ways that you can influence the policymaking process. There was one of our attendees that put in the chat some information about commenting on federal rules through the Centers for Medicare and Medicaid Services. And especially if those relate to equity and the social drivers of health, those will be particularly paid attention to. So that's another opportunity to weigh in, because it's important to remember that policy is made through a number of ways, both through legislation, but then also through regulations and rules as well, and other sources of guidance that federal, state, and local entities put out. So even if there's not a piece of legislation pending that relates to an issue that you care deeply about, it's still important to communicate about that to your policymakers in both federal and state agencies and through your elected officials as well. Always just developing relationships with those who represent you by communicating with them before you even need anything. And remembering that they are just humans like any of us. They come from all walks of life. Some of them have health expertise, some of them do not. They may have been a teacher or still be a teacher. They may be a farmer or run a small business. So helping them to build their knowledge and expertise, being a resource for them early before you even need anything. Those are all strategies that can lead to informed health policy. All right, next slide. Oh, we have some final poll questions for you. Please take a moment to complete these questions or respond to these questions. Again, we do pay attention to the feedback we receive from our webinar and event attendees. Remember to scroll down. This time there are 7 questions that we would love your feedback on. Okay. Thank you, thank you, thank you. We so appreciate you, and we appreciate you sharing your thoughts with us. And last, wanted to make you all aware that we are hosting our very first Ohio Health Policy Summit on October 3rd of this year in Columbus, Ohio. This summit, it'll be a day-long opportunity to learn from national experts and meet people from throughout the state to learn about data-driven policy solutions to address Ohio's greatest health challenges and support the development of new evidence through innovation. Early bird registration just opened up this week. You can find more information about the summit or our other events at hpio.net/events. We would love to see you there. And again, the slides from today are posted on our events page. A recording of today's webinar will be posted shortly. And here are some other ways that you can stay connected with the work of the Health Policy Institute of Ohio. Thank you for joining us, and please enjoy the rest of this beautiful day. Take care.